said there's a technical hitch in them, but I think so now we are almost there. Can I have the... right. Today we are going to have a session regarding refractive surgery. Smile, I think so smile is still the old word, and now what we normally call is it's a lenticular procedure for refractive surgery. So this is what we have, and we are very much happy, and it's a privilege for us that Dr. Kishore Pradhan from Nepal is here, who's a master trainer for lenticular surgeries all over the world, and he has that ability and the perseverance to carry it on for the last so many years, not only in his own country, but he is a lead key speaker in most of the seminars, and also he is the key speaker and keynote talks in when the companies are also involved. I'm just going to start on an introduction, and we being today we have got a different kind of a spectrum. Those who are doing the surgery, who have just started off, and those who are about to start. So in this sense, we are, this stops working. So we have got 3 machines in the world which are coming up. One is Smile, which is the brand name for the small incision lenticular extraction. Then we have got the Clear, which is Zimmer, which is the corneal lenticular extraction for advanced refractive correction. Then the smart side is the Schwind brand, which now it is known as Atos, which is also here. And this is what it is. And it is almost since Walter Squendo started in 2006, and I remember attending his lectures at that time, along with Dr. Shah from India, if I'm not wrong. She was also very much in the start of the lenticular surgeries when it started off. And rest of the thing, I think so, I will leave to Kishore to carry on. And we are, one thing which I would start off, being we have got different machines. One is VioMax, the other is Zimmer, and then we have got Atos, which is not available in Pakistan. As a new users of Smile, and there are also speakers who are being, like Zafrul Islam, who is going to talk about the VisoMax. The awe factor, something which we are normally used to LASIK, we are not finding it in our Smile cases. What does that mean? Is that it takes a bit longer time for the eyes to see 6x6 as compared to what we normally do when we do femto-LASIK. So this is one of our main drawback which we are seeing. Either it is a learning curve, or is it something which you should accept? This is what I would like. I ask Kishore to answer them. With this, I would request Kishore to come over and take over. Thank you very much.
Good evening. I understand. Good evening, everybody, and I have a few words to say before I start. I really thank the whole team in Pakistan who have really made it possible for me to come and give a talk and stand. General Mazhar has always been telling me to come to Pakistan, and I've always been very passionate about Pakistan from the time when I was very, very young. And Nepal has a very big connection with Lahore. So the soldiers who actually go to war from Nepal, they are called Lahoris. They're still called Lowrys. They're taken into the army, but they go to UK now. So they're called Lowrys. I still didn't know the history till I just came. And my wife told me, this is the real story. And she was so jealous that I was going to Pakistan. I've been told so many good things. The people in Nepal are very rugged, the mountains, there's so many similarities, the food. And I'm so blessed to be here. And I pray to God that I get a chance to come back again. Thank you, all of you, sir. So before we start, actually, lenticular extraction has been the main choice for me. I've been a refractive surgeon for almost 15 years now, 25 years as an ophthalmologist. But why? So told me, like, why has there been no wow factor? So let me start right from the beginning. Like, what are we actually really concerned about? As surgeons, what should we be really concerned about? The first thing we should actually be concerned about is the safety factor. How safe it is, how accurately a laser can perform, and the efficacy part. It should be accurate and safe all the time giving you the same results all the time. The accuracy factor. Safety, in the sense, it does not have to be safety in the eyes. When we are talking as an ophthalmologist, we are talking about safety in the eyes. It could be anything else. Have you ever thought about safety on yourself? Is femtosecond laser harmful to you? Or your colleague who is pregnant? Or your nurse? Or somebody? Or something? So safety comes into the whole thing, not only the eyes. The surgery itself should be very, very smooth, easy, and memorable. When a person comes to you and says, I want refractive surgery, it should be so smooth for the patient that it should be like, I went to this doctor in 5 minutes, he or she changed my life. And it should be so memorable. There was no pain, there was nothing. It was amazing. Next day, I can see the whole world without my glasses. It should be so memorable. And again, looking into complications as doctors, if you pull out a hair, you have 10 complications. So the immediate and post-op complications, you don't want the patients to go through all the unnecessary hassles of the life. Infections, infective, non-infective, keratitis, ectasis, all these things should be like, we should be able to handle that very, very easily, very smoothly. Things like dryness, haze, DLK, all these things should be taken care and should be so smooth that the patient should not go through all these. We don't play God over here, but we try and do our best. The quality of vision, that is the most important thing. As eye surgeons, the most important thing is the quality of your vision. So now the quality of vision with all the lasers have been getting better and better and better. With the excimer lasers, they're getting better. With the femtosecond lasers, they're getting better. Your friend, when they see your post-ops, should be saying, they should be jealous of you. When your friend sees your post-ops, say, wow, the vision is so good. See the corneal scans, they're so well centered, so well taken care of. It should be like that when you do refractive surgery. So these should be our concerns, not a concern of whether my laser is working or not. That used to be our concern back in 2010 when I was doing the clinical trial for the VisuMax for myopia, hyperopia. Does it work? Does it not work? It took 6 years for the Americans to at least believe to start an FDA trial. They came to us and then, they're looking at they thought we were lying when we said, no, the lenticule works. Now we are out of that. We are out of that working or not working condition. We are in a different condition. But so many things to talk about. And the safety in the eyes again, like, safe. What does safety mean in the eye? Is like the best corrected vision or the vision that the patient had should not be less than 2 lines than before. So that means you do not want your patient to lose more than 2 lines. So this is the safety, the eye aspect. So lenticule versus PRK. Let me see again. Let's put everything back. Why I like lenticules more is because looking into infections, the lenticule, Smile or Smart Side or Clear or Silk is the Johnson, the new thing. The incisions, the very, very small, 2 millimeters. So that drastically reduces the rate of infection. The uncut corneas, this is hypothetically, it tells the uncut cornea is stronger. Since you don't make a flap, it seems that the cornea is stronger. The anterior cornea is definitely stronger than the posterior cornea. But hypothetically, if the whole cornea is not cut into a flap or something like that, it seems that lenticular extraction surgeries are stronger than LASIK. Less dryness, does not get affected by temperature, altitude, or alcohol. It's temperature in the sense, if it is too cold or too hot, it can burn, it can melt the laser, or it can freeze the laser. But again, temperature doesn't have too much effect on femtosecond laser, or alcohol. Alcohol in the sense doctors not drinking, it is the perfumes. Our lady surgeons, they like to wear perfume when they go to surgery, so they contain alcohol. So alcohol can reduce the performance of excimer laser. Altitude, like in Pakistan, you have very high altitude. In Nepal too, I'm already 1,200 meters above sea level. Does it affect? No, it doesn't. But excimer laser, it can. So what is the world thinking? When you not only in Pakistan now, Pakistan is not thinking very good about the femtosecond laser. But when the whole world is thinking about femtosecond laser, say femtosecond laser, like, oh, my friend has bought a femtosecond laser. I want to buy a femtosecond laser. I want to become a refractive surgeon. I wish I had a femtosecond laser. All these things. They're doing a cataract surgery. I want a femtosecond laser for my cataract surgery. Femto, wow, femto aa gaya, all that. Is it really true? No. Okay, so this is an eye-opener. I'm trying to give you a real, a surgeon-to-surgeon thing. It is not. Will femtosecond laser replace the excimer laser? People are thinking, oh, now femto aa gaya, excimer will go away. No, it will not. Is the corneal biomechanics better with a femtolenticule extraction than LASIK or PRK? No. Will femtosecond replace the microkeratome? It cannot even replace a microkeratome. No. Is the quality of vision better with a femtolenticular surgery? No. So why are we making so much of noise about femto? The whole world is like femto. What's happening? I'll tell you. So with all these advantages that people keep talking about, the cornea is stronger, there is less dry eye, vision is good, all that. From zero, like I remember the day the VisuMax was installed in Kathmandu and the day the VisuMax was installed in China, the same day. So you can imagine. But then, more than 9 million femtolenticular procedures have happened with the VisuMax. And now we have another 3 more companies that have come up. And they all claim to have great results. We have the Schwind with the Atos, which is my favorite. I have 2 Atos femtosecond lasers. I have 1 VisuMax. The Zima is in the market already, and Johnson is coming up with Silk. These are the commercially available femtosecond lasers. With all this, telling us, ye nahi hoga, ye hoga, all that. Will the femto replace the excimer microkeratome? No. Why? Because it cannot pass through scars. Any opacity in the cornea, the laser cannot pass. Very difficult to do keratoplasty on a scarred cornea. You cannot pass a femtosecond laser on a scarred cornea. It'll give you a buttonhole, or it's going to be all irregular, everything. It cannot make lenticules on a scarred cornea, femtosecond lasers, no matter how much of energy you put in. It cannot do PTK. It's very simple. This is why it cannot replace an excimer laser. there is no customized treatment. It cannot do topographic treatments. It cannot treat wavefronts. It can treat lower order aberrations like myopia and hyperopia. Think, I was a retina surgeon 15 years back, and suddenly I had to start with refractive surgery. I had no understanding of high order aberration. I didn't know what coma was, I didn't know what spherical aberration, nothing. But now everybody knows. You go to a resident, the resident will tell you everything. They'll tell you everything about all these high order aberrations. But does the femto take care of it? It cannot. And on top of that, it doesn't have any hyperopic treatments. And the worst of all is very expensive. It is so expensive, the click fees. But still, we are all like, itna mehenga, it is so expensive. There's a click fee to the surgery that's so expensive. And I don't know the mindset, like the femtosecond laser is more expensive. But then again, let's go back. A very simple thing over here. If you want to gift your child a car, your son or your daughter, very simple, let me ask you. The first car over there is a Lamborghini. It is fast, smooth, everything. High-end, very expensive. In 3 seconds from 0, it can go to 100 kilometers. And then you have this Toyota Land Cruiser, which is one of the most sturdiest car, can go through all the rugged regions, can do everything with probably 10 airbags into the system over there. What would you want to give your child? I would definitely want to give my child the big Land Cruiser. This is it. The excimer and the femto. The femto, your immediate visual acuities are lesser, but you know that you will reach there one day, you know. But with the Lamborghini, if you crash, you're 100% dead. The chances of crashing with the Land Cruiser is very little, and even if it crashes, you won't die. You know that. So this is the concept. Now let me tell you, since I've said all the bad things about femtosecond laser, now let me tell you how things have progressed over the past 5 years now. So when I got a femtosecond laser, the Atos, it was exactly like the Visumax. But when you compare the Visumax or any other femto laser with the excimer laser, they're nowhere comparable. But then we realized the first thing we ever wanted when I was doing all the research for Zeiss, I used to always say, give me an eye tracker. I used to go to Germany in Jena. I said, give me an eye tracker. The reason why the Smile is not doing well is because we don't have an eye tracker. We don't have cyclotorsion. And you're not bothered to give us an eye tracker and cyclotortion. Can you give it to us? So in 2019, Schwinn came up with this semi-automated centering device with a great eye tracking system. Cyclotortion, all you have to do is take a scan and put it into the laser. Then came the Visumax. They also understand pupil recognition, they understand the vertex, everything. All you have to do is put it into a scan. Now things are getting developed. This is the development I'm telling you, after telling you all the bad things. Okay? Pupil recognition, treatment offset, everything came in. But the results were the same. There was no difference. Pehle jaisa tha, waise result. We still weren't comparable to the excimer laser. Then we thought probably we go a little bit more customized. Then we said we'll develop the lenticule. So what we did, we made the lenticules differently. It is not parallel to the surface of the cornea with the Atos. In fact, with the silk, it is biconvex. If you look at that, the silk has biconvex to reduce the spherical aberration. Zimmer has it differently. Visumax has it differently. All the 4 lenticules are differently shaped. So the lenticule over here, you see, they try to make a big transition zone, large optical zones, everything. So now the lenticule is a little more customized, but it is not as customized as the excimer laser. a little more customized. And then we went into surgery, same result. The results weren't changing. The wow factor wasn't coming back. We could not compare. Nobody would dare to do Smile or Smart Sight in one eye and LASIK in the other eye. It was so scary. Patient, kya ho gaya mera? Yahan kya ho gaya? Kyun bura dikh raha hai? Something like that. Nobody. Or you could get 20/20 vision the day one, and after doing all the treatments, everything, just before leaving, the patient would say, "Sir, by the way, when will my vision come back?" And he said, "You're seeing 20/20. The patient, the quality of the vision was still not there. Let me explain more things over here. This is stuck. Okay. So the lenticules are differently shaped, Vision Max, all that. The optical zones are bigger, the transitions are bigger, the edges are very smooth, so epithelial remodeling wasn't taking place, regressions were less, but everything again coming to the same, the wow factor was missing. So when we look into all this is just a slide. I want to explain this, I'll explain to you again. So now then we realize the only thing that you could play around, was the energy of the laser. So we decided to reduce the energy of the laser. So when you talk about the energy, it is not one simple thing. It is a big time complex stuff. So what we did, this is a diagram trying to show you an asymmetric transition zone. So what happens if your lenticule is decentered because of angle kappa? If your visual axis is not in the center of the pupil, inferior nasally, and if your lenticule is inferior nasally, in the dark you could have an edge glare. So your night driving could be difficult. So the lenticules are also differently shaped. This is called an asymmetric transition. So it's an oval lenticule also. Even with all these, the lenticules weren't doing very well. So we decided to go down with the energies now. So when we started off with, over here, 120 or 140 nanojoules. Then we decided to go down to 80 nanojoules. But it's not easy to reduce. If you reduce the energy, you cannot dissect. So then what you have to really do was to play around with the spot and the track distance. So what we did was we reduced the energy, and then again the track distance, the spot and the track, we realized we reduced the track also. So we reduced the spot, increased the track, reduced the track, increased the spot, all that, made surgery very easy, very smooth. Oh, we reduced the energy. The result got worse after reducing the spot distance. So what happened now? Jab energy kam ho gaya, the swelling should be less. Then we realized there's something else over there. So now, if you ask me, how much of lenticule do you understand? Probably 5%. In 2015, I was like all over the world, yes, I know lenticule, this. I thought I knew everything. Now I think I know 5%. I'll tell you in 2 years, I'll tell you I know only 2%. Because the lenticule is changing so much, we don't understand anything. We think it is this, we think it is that, but it is not. So every 2 months we realize it's something else, something else. Now we realize it is not the pulse energy, it's something else over here. Then we realize it is the dose. The dose is something else again. Like in a very simple way to explain is your phacoemulsification. You have phaco power, you can reduce the power, but if you go on digging for half an hour, 45 minutes, your cornea will be white tomorrow. Or you could have higher power and do the surgery in half a minute, the cornea is going to be clear. So the total dose is the most important thing. Then we realized there's a formula to the dose. This is the formula. It's very, very simple. Any surgeon can calculate. It's very simple. The dose is spot distance, the energy divided by the spot distance, divided by the track distance, multiplied by 100. This is it. Then we realize we are doing the same surgery again and again. Most of the time, the dose is coming back to the same thing. We've reduced the spot, played around with the track, and then we realize it's coming back to the same thing. The dose is the same. The VisuMax is using the same. Things can be very, very tricky. So if you reduce the pulse distance, there's an example over there, we went even down to 60. But your track distance is so important. If you reduce the track, the number of spots that you put into the cornea is so many that the total dose will increase. So even if you reduce your spot distance, your pulse energy, the amount of dose that you're going into the cornea is so high. Then we realize, okay, we got to play around with the dose now. So reduce the pulse energy, play around with the spot and the track distance, make it very asymmetrical, have a good surgery, and then we realize it is not only this. Probably there are so many things that is hiding now. Now we're thinking it is the dose. Probably it's not the dose. It could be something else. We don't know. Tomorrow something else will come up. So what we did, we tried to do another study. Okay, this is just the geometry of the lenticule. So this is just for people who are just trying to understand lenticule. What is this? This is the lenticule. This is the cornea. The corneal nerves. What I'm trying to show over here is the nerves are actually uncut nerves. The cornea is uncut cornea. So the cornea, hypothetically, it is stronger. The nerves are intact, the nerve endings. So dryness is less. The incision is small. This is something I'm trying to tell hypothetically. But Dr. Rohit Shetty in Narayan Nethralaya, he proved to the whole world biomechanically, LASIK, PRK, and SMILE. The biomechanics is the best with PRK. SMILE and LASIK, or lenticular extraction and LASIK, they have similar biomechanics. In fact, he's been getting more ectasias with SMILE patients. We don't know. The lenticule has come very recently now. We don't know. There might be a big wave of ectasias coming after a few years, thinking that, oh, cornea was very strong, cornea is strong, hair strong, and then we don't know. Something might be coming. But biomechanically, this is what we were talking about it in the past. The nerves are, there's less dryness, cornea is stronger, all that, but now we find out that it's not the case. So what I'm trying to say is, every time you think it is like that, it might not be, because this whole universe is so much to teach us more. We haven't learned anything. Now this is the energy. So for example, if you're using large amount of energies, you're using, the surface is very rough. There's a bombardment, 1 femto, large pulse energy, there's a big bombardment. If you're making a 4 micron large spot energy, it might give you a 6 or 7 micron spot size and a big pitting. And on the lower floor, I'm trying to show you that lower energies give you smoother planes. So the surgeries that are easier to do with lenticules are the ones where you have put more energy. Tomorrow the vision is going to be worse than the surgeries where it was difficult to operate. So this is the electron microscope picture of, this is published in Korea, about the two energies. Just see, in 10 nanojoules only, it is so much smoother with the lower energy. So the lower the energy that you do, the smoother is the cornea going to be. So we've done a study with so many things. One is with the energy again, with low energy, asymmetric pattern, where we've taken 2 groups of people, and there's done another study where we've taken about 86 parameters. So 86 parameters, whatever that could come to our mind, the corneal thickness, the endothelial cell count, the shape of the cornea, the age, refractive, everything. And then we tried to analyze the whole thing, and with low dose came this result. Sorry, let's go back. We realized there are 3 primary components we've taken. The first primary component all the laser settings. That's the energy of the laser is the most important. And the primary component 2 and 3 are the biological factors from the patient. The patient's age, refractive errors, all that. So with very, very low dose, suddenly, if you look at our results, 92% of the patients, 2020 day 1, 92%. 42% of patients are 2016. This is very, very good result, but still not as good as the excimer laser, because I think LASIK, 98% of the patients are 2020, like if they were 2020 before. But if you look at the comparison to 2022, 82% of the patients for 2020 in 1 week. We were still struggling to get 2020 in 1 week. So these were my VisuMax as well as my ATOS results. These are something like that. But now suddenly with lowering the energy, the results are much better. It is not wow, wow, wow like the excimer, but it is very much comparable. If you do LASIK in one eye and SmartSight, your lenticule in the other, patients are much happier. They don't realize it now anymore. It was also published. Even the astigmatism now, if the cornea is less swollen, you don't induce astigmatism. So the total amount of astigmatism is within 0.5 diopters. 100% of them are within 0.5 diopters in day 1. So most of the results are amazing. So this is a video of how this is the video of the ATOS. Okay, I'm just trying to, before docking, how these lasers have become, how advanced they've gotten. I don't know, so this is again the latest version. I don't know if you saw it in Dubai, it wasn't there. So every 3 months, something new is coming up. So as you go away from the corneal vertex, it becomes red. You go closer, it becomes yellow, and it's very close, it becomes green. So if you look at that, the laser can track everything. The small circle is about 200 microns. You can see the patient is so relaxed and is turning the clockwise over there. You can actually see how much of cyclotorsion is happening. It's calculating. It's like almost 12 degrees over there. And when the patient starts squeezing, it's the other way around. You can see, it'll tell you. So now the lasers are so good, they can tell you on the table like how much of cyclotorsion is happening, where, what's going on. So almost 15 degrees of cyclotorsion can happen in one eye on the table. So in high astigmatism, this is a big thing. So we've been relieved of marking the cornea. You don't have to mark the cornea. You don't have to take the patient to the slit lamp. It's all done by the laser itself. Let's cut that out. So even the surgeries now, if you look at this, the ATOS, there are very little OBLs, hardly anything, so smooth. But again, not only the laser is important, it is also the surgeon's surgical techniques are also very important. So before, when I was doing my surgeries, most of my techniques, like I would go rub, I counted, then I realized I was rubbing the cornea about 27 to 30 times, even when I thought I was doing a good surgery. But now I realized rubbing the cornea can also induce swelling. So if you can do it in one sweep, up and one sweep down, with very, very low energies. So these are the patients who will have great results immediately. So a little bit now, let's go. I have few slides, please don't sleep off. I have about 3 slides now. So the study we did on the eccentric and intrinsic factors. So eccentric factors are factors that are biological, the patient's factors, and the ones that really affect the visual acuity. The date of birth, we realize younger patients get better vision. So when you're choosing your patients, it's very, very important. Younger patients, we don't know why, could be that the endothelial cell count is more, the swelling the next day reduces faster than a person who is my age, okay? The treatment date, larger the better, means if a surgeon has done 5 surgeries and you compare that person's surgery with the surgeon who has done 1,000 surgery, so the longer the learning curve, the experienced surgeons will definitely have better results. Spherical equivalent, we see that high myopia gives you minification. The image becomes small. The moment they get rid of the glasses, they gain a line because the real image is bigger. Cylindrical power, higher the cylindrical power, worse is the result. So after I've realized after minus 3, 3.5, tomorrow the results are not great, but they do come back because of the opticals. The target, higher the better in the sense the accommodation. Younger patients, if you have a plus 0.5 or a plus 1, they accommodate. They can easily accommodate pluses. On top of that, the pupil constricts, they converge. The conversion, constriction of pupil also helps to better vision. Keratometry is very important. Steep corneas do worse. Steeper corneas, there's more deformation. When you put the treatment pack on the cornea, you can deform the cornea more. So the vertex is pushed somewhere else. So flatter corneas do better than steeper corneas. We've realized the day one steep cornea results are worse than the flat ones. The epithelium, I don't know how many people really look into the epithelium. The epithelium is very, very important. So irregular epithelium in cases of corneal scarring or ABMD, or if you have an epithelial defect after surgery, the result is not as great. So you should have smoother epithelium post-op. And the intrinsic factors, again, large optical zones. Cap thickness, I usually like to keep a big cap thickness, about 135, 140 microns. Energies, lower energies, like the larger the energy, the worse it is. The spot distances, larger, the better. Track distances, smaller, the worse. I'm just trying to tell you so that at least you start thinking, what the hell is this? What is spot distance? What is track distance? Then you start calculating. You know the formula now, okay? And then you have the dose. Higher the dose, the worse. Higher the power, the worse. Asymmetry, higher the asymmetry, better. So this is now where the femtosecond world has come into. Now everybody's talking about dose, power, energy, all that, more than eye tracking and cyclotorsion. So again, of which the biological and the laser factors, it is always the laser factors are more important getting great day one results. So in conclusion, I would say lenticule surgeries have really opened up with more than four of them available commercially. Lenticules are getting more and more customized. Treatments are getting more accurate, more safe. Complications and hazards are very little. Other things like hyperopic treatments and customized treatments are on the way. In 2 years, both of them will be there. Thank you so much.
Thank you, Kishore, for your excellent presentation. And welcome to Pakistan. Last time we met, I said, please come to Pakistan. You are on Nepali. We'll show you some real mountains. So maybe this time you won't have time, but next time you come, we'll take you to the mountains. So just a joke, because they have better mountains than us. So we're running short of time. I think Amir is up next with the complications of lenticule.
Thank you, Kishore. It was a nice presentation. We do have like lenticule, but I think my liking is always going in with a femtoLASIK, because I do not get a wow factor, and that is pretty important for me. That brings in more patients, and that brings in more satisfaction to my patients. I've been doing Smile for last almost 7 years now, and still femtoLASIK is the main gear that I use. I've got Clear and VisuMax. Basically, there is a bit of a learning curve when we talk about going in for a lenticular extraction. because and it is far more quicker when we talk about femtoLASIK. There are like different things about femtoLASIK, as Kishore has already mentioned, that one need to be really aware of, especially when we are starting, and then that is the time when we can really have some teething problems. This is one of the cases that I did about a couple of years back. This is the start of the video in which you can see after docking, as soon as I started getting OBLs. OBLs are indications that they are going to be more adhesive. I've got a complete no problem with suction or anything. Got this properly dissected thing. You can see like hindrances coming up. I could feel the resistance going into the anterior and the posterior surface of the lenticule, and even trying to separate the posterior one. I was really struggling. This is not my first case, but still it was a little difficult to get into the pocket. Once I managed, when I was dissecting in the anterior surface of the lenticule, I could see suddenly this thing gave away and the spatula came out. Now this is where the important thing comes up. Is first thing is like never go in this area if such a thing happened. We have discussed it with my friends who are into the lenticle thing. I think we share a common friend, Dan Reinstein, who also thought about it like to be like something that he has never come across. I dissected the whole area around it, but never went into this affected area. Once I had the anterior and the posterior surfaces dissected completely, then I went underneath the lenticule and dissected away the undersurface, and it was quite easily taken out. Next day, I was a bit skeptical about how the cornea is going to look like, whether it's going to have any effect onto the refractive surface of the cornea, or it's just going to be like simple. So, sorry. Next day, when I saw it on the slit lamp, the patient was pretty happy. There was no problem seen. The scar was gone. And to finalize it, I also did a pentacam to find out if there was any effect on the refractive element, and I could not find any. So these things can be like really scary, but they are quite forgiving at the same time. So just wanted to share this video with you. Thank you so much. Thank you.
Thank you, Amir. I think Dr. Zafar Islam is going to tell us about the future of lenticule extraction.
Good afternoon, dear ladies and gentlemen. Thank you, Chair Shehzad. Most of the talk has been actually covered by Kishore, and now we saw the complication that must be very discouraging for the one who is willing to start. Actually, where in the beginning it's a bit steep learning curve, but once you master it, then results start getting better with the time, and that wow effects start appearing. That's what my impression is, and what my experience is actually. I'm doing it for the last 7 years again. I just started before Amir Israr. So I won't discuss it because these things have been discussed, and it's a very simple two-step techniques, and I will go quickly forward. And this is a video. I don't want to show it again because this video, can we go back? I mean, it's bit automatically running. I don't know. Oh, sorry. So it's a small incision, but it's a big advantage, I would like to say, that it's flapless. It's all femto single platform. That is the advantage. You save time as compared to the femtoLASIK. And then there's less nerve damage at 130 micron depth. Specifically, 130 is the best one because most of the subbasal nerves are preserved, and then there's less chance of dry eyes. They have studied it that with 110 depth, there was more chances of dry eye. And again, the biomechanical strength is debatable. I mean, a lot of study have come and they said no, it's the same as LASIK. And the one who belong to the companies, especially the Zeiss one, they always claim that biomechanical strength, we get it. I do think that it's the same with LASIK, so your residual stromal thickness should be in mind as it's in mind with the LASIK. ये नहीं है कि अब आप कहें कि हम 200 पे भी कर लेंगे, छोड़ देंगे और हमारा गुजारा होगा, no. So SMILE was introduced by Zeiss in 2011, but they had monopoly for 10 years. But then more companies came, and results are coming in 2023. So the better term is now refractive lenticular extraction, RLE, although it's a bit confusing because we have been using it for that is refractive lens exchange, RLE. So probably that name has to be changed. So these companies, Johnson & Johnson's introduced Silk, Zeeman introduced Clear, and Schwind introduced Smart Sight. And now probably General Saab is doing Zeemer, and I just mentioned about the Smart Size by Kishore. So all these companies are not only these companies are coming forward, but a lot of new changes, advancement are coming, like auto-centration. That is very, very important. These are recent advances. Static cyclotorsion control is very, very important. We have just seen the video. That was very interesting video. So that's fantastic video. And then, as has already been mentioned by previous speaker, that lower the energy, high speed, that has contributed to the better results. So जितना आपका हाथ बेहतर होता जा रहा है, टेक्नोलॉजी भी बढ़ती जा रही है, so you are getting better and better results. तो जो एक फोबिया है, फियर है कि भाई इसका वाव इफेक्ट नहीं है और इसमें वो हमें नहीं नजर आता, that is really not there once you get used to it. So what's the future? It has already been mentioned, hyperopic correction. Yeah, I mean, that work is going on. There has been problem because there's large mid-peripheral transition zone, small, and eye itself is a bit smaller clearer zone. So there are studies on it, and people are giving good results, but still clinical trials are going on, and different platforms have formed. But one of the major problem has been a post-operative regression because of compensatory epithelial thickness in the mid-periphery that negate the effect of that laser. Then this work is going on presbyopia correction. We have seen it in LASIK and PRK, that is presbyLASIK, where the rings are produced, or blended vision, where asphericity has been applied, and they are working on it. Similarly, they are working on tropo-guided and waveform-guided for the refractive lenticular extraction, but it will take time. That is coming. So future is exciting. So I would say that don't be afraid of it. And then ReSmile, that is a big question. If we want to do research, normally we go for the PRK or LASIK. One thing we can do is the circle. You put the circle and same interface you use, lift it and do it. That has been done. And I don't know how they will go to the same one, same interface and do the ReSmile. Just can't say, but that's what's lying in the future. So in conclusion, I would say that refractive laser has witnessed rapid progress in terms of cutting-edge technologies, novel surgical techniques, and more precise visual outcomes. In near future, all three methods like surface ablation, LASIK, and RLE will stay in vogue. I mean, it doesn't mean SMILE agar aa gaya to aapka PRK khatam ho gaya. Rather, for foreseeable future, these all three will be there. Because बहुत सी जगह आपको PRK करना पड़ता है. Flapless corneal refractive surgery has become a reality, and is at par with LASIK in terms of precision, efficacy, and safety profile, and better as it's flapless, as there is less chances of a dry eye. And lastly, innovations in flapless surgery offers us endless opportunities to not just rid the patients of their spectacles, but also elevate their quality of vision and life. Thank you very much.
Okay, so briefly, can we just take some questions? And I'll start with a question. Sir, I am a refractive surgeon. I like to think I am. I don't have the guts to start SMILE or a lenticular extraction because I have to struggle with just lifting one plane up during my femtoLASIK and making 2 dissection planes at a deeper level from the surface of the cornea and removing that lenticule out through a small incision is too daunting for me. So this is my comment. The other thing is, we would like to know, because you 3 are experienced lenticular surgeons here, and we have a lot of young people there who are, the future of refractive surgery. Could you just go through the learning curve and the process of how are these guys going to learn lenticular extraction in Pakistan setting? I'll start with Zafar Saab.
Look here, no doubt, learning curve is relatively steep. But as I have already mentioned, that the technology बढ़ती जा रही है, नई चीजें आती जा रही है, आप इसको खत्म नहीं कर सकते. The thing is that what I suggest to the people that they attend a lot of international conferences, and there they have very good platform that is wet lab platform where they are doing it. So I suggest everybody they should do SMILE whenever they go abroad or whenever we arrange it here. So they will get the experience of that. The second thing I would say that that first few of your cases, it must be under supervision. So there must be a trained surgeons. That SMILE surgeon, I would say, but lenticular you can say. Lenticular surgeon should be around because this is my experience that after about 20 or 30 eyes, you become really very good. And you know where the lenticule edge is, where you are going, how much force you have to apply. And then you start changing in your energy and those part distance, track distance, etc., etc. So, my message was you shouldn't be afraid of it. The only thing to afraid is the money that you have to buy a machine that makes it really very, very expensive. And for each patient, you have to give up 350 or 450 euro to the company. That is something I would say. वो मुझे भी बड़ा disturb करती है जब मैं company को पैसे भी दे रहा होता हूँ. That is disturbing.
Amir, would you say 20 eyes is enough as a learning curve for supervised?
What I think is like, for me, I think especially Kishore and you, Professor, nobody was around when we were learning and we got through it. So it's not that difficult that somebody's got to be around and somebody's got to teach you. The only thing is if one has got like enough of a knowledge of how to deal with complications with femtoLASIK and you've done your homework properly, it is quite simple to start with. I practically think it's just like jumping into water to learn swimming. The other thing is like one thing that from internet that we come across is like SMILE is a superior procedure than femtoLASIK, or femtoLASIK is a superior procedure than the other one. PRK, femtoLASIK, and SMILE, they all complement each other. You'll find a patient who will be more suitable for a SMILE and the other one might be suitable for femtoLASIK. But as Kishore mentioned in his talk, never try or attempt a SMILE in one eye and a femtoLASIK in the other one. I just have one patient in which we had a suction loss at the end of the procedure, so we could not continue on with the SMILE procedure and had to do a femtoLASIK in the one that there was a suction loss. Patient is still very happy with the eye that we did femtoLASIK on. because it's been like embedded, although he's got good vision, both eyes, but the thing has been like embedded into the brain that my left eye got far more quick recovery as compared to the right eye. So like these things are there, and they are tools to be used, and I think once you start it, you'll get the hang of it.
So Kishore, about training for femto-LASIK and the learning curve for prospective refractive surgeons.
See, learning anything is very difficult. Anything. It's like learning to walk and then try to run. And smile is something like you're trying to run without learning how to walk. So there was a time when you were not allowed to do smile without doing 2,000 LASIK. You had to do 2,000 LASIK, then you had to do 500 flex, which has disappeared now, and then only you could do smile. So I was the first surgeon who did smile before then my LASIK. I realized smile was easier than LASIK. So Professor Dan Reinstein was behind me. And I realized there's so many things for a LASIK. You have the eye tracker, the buttons, and this, lifting the flap, moving the patient from one side to the other. And my first surgery I ever did was a smile. And the next day I did LASIK, I found it so difficult. But then there are times where I have abandoned the smile procedure because I could not find the lenticule. So that's very scary. Not being able to find the lenticule is the biggest fear for smile surgery. So what I do for people who come to me, so there's a package for the company itself. They come to learn to me, and I make sure that when the person is starting, I go to the person and stand there for at least 2 or 3 days when they're doing the first 20 to 30 cases. It takes about 40 eyes, which has been published. 40 eyes is where your surgeries are going to be smooth, same time, same result, and like with the same confidence. So the first 40 eyes, you will struggle. Like with anything, with driving or riding a bicycle or doing LASIK, you will not believe, if I show you my LASIK complications, there are times where I stopped surgery for almost 6 months. I had patients with flaps gone, I had flap melts, and you will not understand. Unless you see, if I can show you my complications probably tomorrow or somewhere. I have had such bad days with LASIK. So this is the reason I keep sticking around with my lenticule. I know a day will come. I've done thousands of LASIK, but then there'll be one LASIK that will really pull you down. And it'll be a VIP. The Prime Minister's son or somebody. Or your doctor friend's son or somebody.
So the last time I met you in Dubai, you had lost some weight because of some high-profile patients who had...
The Prime Minister's wife's flap was gone the next day.
Was that a LASIK case?
LASIK case.
Wasn't a smile case?
No, smile is nothing. In 2 days you can start swimming and all.
Okay.
So with the flap, the Prime Minister's...
And that was a femto-LASIK or LASIK?
Femto-LASIK.
Femto-LASIK.
She didn't put on a shield and she went to sleep with the face on the pillow, and the next day the flaps were gone. We put the flap back, but then again we had an epithelial that grew. Then there was an inflammatory membrane and all that, and there were 10 surgeons from India and 5 surgeons from UK and some surgeons from, I think there were 50 people working on that patient. And again, still, the funny part is the flap melted all together and the vision improved after that.
Okay. So it has turned out well, I suppose. Did she lose 2 lines or not?
No, she didn't lose. I said the vision improved after that.
Any more questions from the audience, please?
Actually, just a comment that this kind of flap problem usually occur when you make a thin flap like 90 micron or 100 micron, then there is a very high chance that it may slip, and for fibro, there is striations of those kinds of problems.
If there are no questions, so we'll conclude the sessions and the shields will be presented.